Hello everyone, my name is Jennifer Beckman. I'm a clinical nurse specialist and I'm going to talk to you about alcohol withdrawal syndrome. And we know especially since COVID, alcohol use is increased quite a bit, and well, all abuses are increasing quite a bit. So the world is really looking at this and trying to get it under control. So we're going to talk about that in an acute care setting, what that is about. So our objectives for today are to discuss the prevalence of alcohol use disorder according to the National Survey on Drugs Use and Health, to discuss the prevalence of patients with AUD admitted to the acute care setting, understand the different disease processes that people have AUD are at risk for, and describe the pathophysiology of alcohol withdrawal syndrome, or AWS, and factors that predict the severity of alcohol withdrawal. The last is to discuss the use of the CIWA assessment scale and appropriate treatment for alcohol withdrawal syndrome. So according to the National Survey in the year 2021 on drug use and health, they found that there was 28.6 million adults ages 18 and older, and 11.3% in this age group. So of all the people in the world, it was 11.3%. 16.3 million men age 18 and older, so 13.2%, and 12.4 million women ages 18 and older, which women used to be a lot less in the past, but we're catching up. Woohoo, something to be proud of. So 18.2 million white adults age 18 and older, and that's 11.5% of this age group. 4.9 million Hispanic or Latino adults age 18 or older, and that's 11.4%. And 3.4 million Black or African American adults age 18 and older, and 11.1%. So everything seems to be mainly in the 11s, it looks like. 96,000 Asian adults age 18 and older, and it's 6.4% in this group. And 270,000 American Indians or Alaskan Native adults age 18 and older, so 16.7. So they have a higher percentage than most of the groups. And then 118,000 Native Hawaiian or other Pacific Islanders, and there is 13.4. So it's, smaller group, larger amount. So that's probably the reason why that occurred. So what is alcohol use disorder, or AUD? It is estimated that more than 140,000 people, approximately 97,000 men and 43,000 women, die from alcohol-related causes annually, making alcohol the fourth leading cause of death in the United States. That's a lot. So, it's not necessarily from accidents and that, like 50% are from disease related, because there's a lot of problems that occur from alcohol abuse. For patients undergoing elective surgery, acute alcohol withdrawal was associated with perioperative complications, 40% higher overall cost of treatment, and 85% longer length of stay. And a lot of these people come in and they don't tell you that they drink because they don't think they have a problem, and they don't want to talk about it. But if they do, we can prevent a lot of problems from occurring. Patients with AUD have increased risk for alcohol withdrawal syndrome, and when alcohol is abruptly discontinued, as in the case for those patients admitted to acute care hospital. So they come in, they don't tell you, and all of a sudden they're climbing the walls, and the wife says, oh yeah, he drinks, fifth of vodka a day. Thanks. So in the United States, more than 20% of the patients admitted to the acute care hospital setting meet the criteria for AUD, and more than 2 million patients withdraw every year. So why do people drink? The main reasons are enhancement. It makes things more exciting, more enjoyable, 2, coping, just to get away from the worries. It kind of wipes the slate so your brain's not thinking as much. 3, social, to celebrate things with other family members or friends. And 4, to conform. And that's probably the biggest thing with high school kids. They want to conform to being cool with the others, having shots and stuff like that. So alcohol use disorder is a medical condition characterized by an impaired ability to stop or control alcohol use despite adverse social or occupational or health consequences. So the symptoms of this are they have a strong need or urge to use alcohol. They come home, they have to have that drink. Unable to control their drinking. Once they start drinking, they drink till they're plastered. They can't say, oh, I've had enough. They just keep going. Unable to stop drinking even when it causes problems. So if they get in a car accident, they get put in jail, whatever, it's not their fault. It's, just a bad day. And then having withdrawal symptoms when they rapidly decrease or start drinking or stop drinking. So they start having symptoms of withdrawal. Could just be anxiety, could be agitation, could be tremors. It's hard to tell. And frequently thinking about decreasing amount of drinking without being able to follow through. So they think about it. They're thinking, maybe I do drink too much, but then they can't really do anything about it. So half of the alcohol-related deaths are because of health effects from drinking too much alcohol over time. So it's not only that you're getting drunk, it's also that it takes a toll on your body and can cause a lot of problems with health issues. And if 40% of the people are dying because of health-related effects, that's a pretty significant amount. So, you can say, well, I'm not an alcoholic, but you can still get all the potential problems from drinking too much. And so people that have AUD disorder have a greater risk for some disease processes, such as liver disease. Well, that's kind of pretty well known because that's where alcohol is broke down. Cardiac disease, so they can have cardiomyopathy, they can have hypertension, they can have a lot of different things. Depression, because it does make things mellow. At first it makes you happy and go lucky, and then it can also bring you down. Can increase risk for having a stroke, increase risk for GI bleeding. That's probably a really high cause of GI bleeding is people that are alcoholics. And different types of cancers. Now, a lot of these are related to the fact that some people don't have an enzyme that can digest alcohol. And it seems like the people in this group tend to have more problems with cancer. So like cancers of the oral cavity, esophagus, larynx, pharynx, liver cancer, colon cancer, rectal cancer. So it seems to be a big problem with that. So not only do you maybe lose your family or lose friends, you also lose your health. So what is a dietary guideline for drinking alcohol? And for women, it's 1 drink or less a day. And for men, it's 2 drinks or less in a day. So for heavy drinking, it's considered that women who have 4 or more drinks on any day or 8 or more per week. So if you're really tossing them down, that's considered heavy drinking. And for men, it's 5 or more drinks on any day or 15 or more per week. So there's some things to think about with this is when a person drinks is how much and how fast a person drinks influences how much alcohol enters the bloodstream. And it shows the risk that they're willing to take. If they're putting a lot of shots down, it's going to enter in quickly and they'll get drunker quicker. So, and over time, how much they drink over time and how often a person drinks shows us the acute risk they are taking as well as the chronic health problems that can occur. So it's the bingers that do the little bits maybe they're not going to have as many health risks, but there is a lot of other risks that they're going to have. So what is considered too much? So some of the things that are factors to look at when addressing if a patient is at risk for alcohol-related problems: how much and how fast they drink, because if they're just trying to get drunk, it's a pretty good sign that they're probably doing this pretty regularly. Over time, how much and how often a person drinks, it's really kind of a big deal, because if they're drinking, you know, I don't know, 10 Guinnesses a day, that's quite a bit, because that's a higher dose than what your regular drink would be. So what counts as a drink? So in the USA, this is kind of the standard drink or alcoholic drink equivalent is any drink containing 14 grams or about 0.6 fluid ounces of pure ethanol. So the picture kind of shows what this would look like. So for a 12 ounces of regular beer, it's about 5% alcohol, so that would equal to what they consider a standard drink. And when you get to the 8 to 10 fluid ounces of malt liquor or flavored malt beverage, much as hard seltzer, and shown in a 12-ounce glass. So it's about 7% alcohol. So we should be drinking a little bit less than a regular beer. And then wine, if you're drinking table wine, you only get 5 fluid ounces, and it's about 12% alcohol. And then 3 to 4 ounces of fortified wine. So that's sherry or port, which usually they serve you in smaller amounts, or they should be doing that. So it's usually like 3 to 4 ounces they give you, and it's about 17% alcohol. And then cordial or liquor would be 2 to 3 fluid ounces, and it's about 24% alcohol. And then if you're going to have brown brandy or cognac, it's 1.5 fluid ounces, and it's about 40% alcohol is what it should be. And then if you're going to have shots, so we know people like to do shots, it's like 1.5 fluid ounce shot of distilled spirits, gin, rum, tequila, vodka, whiskey, and it's generally 40% alcohol. So that's kind of a standard drink to think of. So if I tell you you can have 2 drinks, or it should be 1 drink a day, so 1 glass of wine, 5 ounces. Now, you know we have bigger glasses than that, and our patients will tell us that they're drinking 1 glass of wine, but it might be one of those glasses that holds a whole bottle, which is pretty amazing. So just, think about what that stands for. Hi, so on this slide, we're going to talk about pathophysiology of alcohol withdrawal. And it's kind of a diagram, a little confusing, but it works pretty well. So the GABA and the glutamate, there are receptors in the central nervous system, and the receptors in the, the GABA and the glutamate, they're in the central nervous system. And the GABA is kind of for quieting, and the glutamate is for increasing energy, excitation. And in your body on a normal day, the GABA is even with the glutamate. They're the same. So on this, they're the same weight, so same level, and they are the same. Now, when we add alcohol to the GABA with the alcohol with it, it becomes heavier and draws the teeter-totter down, and the glutamate goes up. So the GABA is actually greater than the glutamate because it has alcohol on board. It's making it heavier. So then we go to the next line, which is habituation, chronic, and regular use. So the GABA and the alcohol, the glutamate has increased its weight, so it's evened out. So what happens in this state a lot of times is the patient starts feeling the same, the GABA, the alcohol, and the glutamate becoming one, and it wants to have more alcohol. So it gets that same effect. And then in the withdrawal state, where the person just stops taking alcohol, The glutamate is, so it's the alcohol's gone, so GABA's what it was, and the glutamate, which was higher because it had to compensate for the alcohol, is now heavier, and so that teeter-totter is down. And the glutamate is kind of like, it's the excitement phase. So we get acute excitation, we get those withdrawal symptoms. It's kind of like having wild, like the telephone pole and the wires breaking. It's wild. They're all over the place. Nobody should go near them. And it's setting all these different things off of signs of withdrawal inside that person. How do we control that? Is we put the benzos, and then the benzos take the place of the GABA, or take place of the alcohol. So the benzos are in place of the alcohol, so the GABA comes, and then it brings the glutamate to a more even keel. So that's why the benzos work. So they're taking place, they're covering up those wires so they're not so electrified. And then as time goes on, the benzos are weaned while the GABA is building to a normal level, and then the two are even again. So it's a very confusing slide in some ways, but it actually is kind of how it is seen. Okay, we'll go to the next slide. So on this slide, alcohol withdrawal syndrome, the diagnosis of alcohol withdrawal syndrome, or identification of the potential for alcohol withdrawal syndrome, is based on history, clinical observation, and laboratory studies. So one tool that can help you see how severe your patient's alcohol withdrawal may take place is called the PAUSE risk assessment tool. And it's looking at different factors, different risk factors, and it'll kind of tell you this could be bad. So a blood alcohol level greater than 200 on admission. It's pretty high. It's telling you they probably drink quite a bit. A history of previous withdrawals. They've gone through this before. They're telling you the drug that works for them. 3 is blackouts. 4 is combined substance use. And the last one is frequent episodes of intoxication. And that's that. We'll go to. So the phases of alcohol withdrawal syndrome, we have phase 1 is within 5 to 6 hours after alcohol level drops below the habituated level. So you have to understand is if these people drink the same amount every day and they come in and their blood alcohol level is 200, their habituated level may be 100. That may be who they normally are at. So if they go up to 200 and they're really intoxicated, and then you wait, you admit them to the floor, and 5 to 6 hours later they get down to 100 and start going below that, this is when you might be seeing the withdrawal symptoms. Also, another thing is the body knows, it develops habits, and it knows when you usually drink or when a person usually drinks. So if, let's say, Saturdays at 4 o'clock or when I usually drink, and I was a heavy drinker and I was used to it, my body was used to it, and it came along Saturday and 4 o'clock comes, I want to have a drink, because you have that craving for the alcohol and they have that craving. And if they may, not show anything all day long and look really good, and you're thinking, man, we're good, we're going to get them out of here. And at 4 o'clock they start having symptoms because their body knows when it was supposed to do this. It's really kind of amazing how you can see people change very quickly. So what they have is a craving for alcohol. They know they want the alcohol. They have insomnia if they're, it keeps them awake. They have vivid dreams that they do get to sleep. They have anxiety. They're really nervous about things. They're irritable. They get restless. They're yelling. They have headaches, and the light might start bothering their eyes. Their heart rate goes up. They might develop tremors in the hands and sweating. You know, I remember when I was a new nurse, you know, I was kind of naive about, but I would see these guys and, you know, we were giving them meds, but I didn't put it together because I wasn't that bright. And I would see this sweating, so I would think they were going through septic shock or something. And I was trying to turn it into something big, but it was really just the fact that they were going through withdrawals from not drinking. And then there's nausea and vomiting. So they kind of get sick to their stomach and they start vomiting. So phase 2 is 15 to 30 hours down the road. And it's after their alcohol level drops below habitual levels. So you saw the 5 to 6, so they had a little sweating, maybe a little agitation, having problems sleeping, and he reaches 15 to 30 hours without alcohol, and he still hasn't told you that he was going to do this, or your doctor's not paying attention to you when you're trying to call them, and they might have convulsions. Usually 1 or 2 grand mal seizures occur in 5% to 15% patients. And I've only seen that once on my unit since we've been doing a lot of CIWA. And typically occurs when within 6 to 48 hours after all alcohol cessation. You know, some people think they don't have a problem. They were like, I can quit anytime, or they run out of money and they don't know that they don't have any way to get alcohol, and then they'll have a seizure, and that may be what brings them in the hospital. It can be lethal. The risk of seizures increases with prior history of seizures or DTs with withdrawal. It's called the kindling effect, and I'll talk about that a little bit later. And then they have a prolonged use of alcohol. So these are the people, usually seizures are pretty severe, and but you have to make sure it's related to alcohol, not something else. And then phase 3 is 3 to 5 days after withdrawal. So it starts with delirium tremens, but it only occurs in less than 5% of the patients, and thank God, because it's really a miserable thing to have. And you can't prevent it if you start taking care of them at phase 1. A lot of times you can prevent them from going to phase 3 with the medications. Some people you can't on the PCU level of care, and they have to go to ICU and be intubated and put basically out while their body's trying to heal. Sometimes you can keep it down if you have a nurse that keeps on it. On the PCU level of care, starts them on the meds and is really religious about giving the appropriate meds at the appropriate time. But it's really scary when they get going. It's just overwhelming because the symptoms are disturbing hallucinations. So they're seeing things, they're hearing things, they might even be feeling things. And it can be really quite disturbing. So they might see spiders on the walls. I remember I had a patient who called me into the room and said, I'm seeing there's a spider on the ceiling. I thought, oh no, we're going through DTs. I looked up and there was a spider, and I was very happy. So make sure that they're not really a spider around before you get too whacked out about it. So disturbing hallucinations, they're hearing things, they might be feeling like ants or bugs are crawling into their skin, and they'll start itching them. They may even get so bad as they rip their skin because of they don't have any idea really what's going on. They have bizarre delusions, thinking people are laughing at them, maybe thinking about people are after them. They can get really agitated and break things. I had a guy once bent an IV pole. That was a horrible moment. I was just looking at him, and he just stood there and looked at me and bent this IV pole. And then confusion, can be very confused. They have no idea what's going on. Hyperthermia and disorientation. I can't say I've seen the hyperthermia because usually I can't get a temp on them when they're that bad. And the death rate is 2 to 10%. Death usually occurs to cardiovascular issues, metabolic issues, infections, complications, or aspiration. And hallucinations occur in 3 to 10% of the patients are usually visual. So they're more seeing things than they are hearing things or feeling things, but they usually itch quite a bit. So what do we do? The main medications that help these people are the benzodiazepines. And they help because where that alcohol sat on the GABA, they sit there. And so they keep it under control while you're waiting for the body to physically adjust the neurotransmitters to where they can work together, where they're even again, and you won't have these issues. So some of the common ones and the ones we always used back in the good old days was diazepam, and Valium. It has a really quick response and longer half-life and prevents rebound withdrawal syndrome, so it holds on for a longer time. It can be problematic with the elderly, and we don't give it as much anymore, although this last year the Ativan was at a low level, so we had to go to Valium. That was the drug of choice at that point. And then we have Ativan or lorazepam, and it's used for those patients who have impaired liver function. So if you call your doctor for medications, you kind of need to know how bad his liver is, because if it's really bad, then we may not use Ativan. But in most cases, Ativan is the drug of choice. And chlorodiazepoxide, Librium, longer half-life, prevents rebound withdrawal symptoms 2 to 3 hours to onset, 10 hours half-life. So it's a little longer. And some docs will order this around the clock and then use Ativan or Valium for breakthrough. So it helps by mimicking the effects of alcohol on the GABA system. So it's like replacing it and trying to ease that system to even out. And this can take several days for the neurotransmitters to equalize. Patients must be medicated consistently during the entire withdrawal period as per the CIWA AR score. So we're going to talk about that here in a bit. And warning on giving patient with age greater than 60, which I'm greater than 60, so don't give these to me. So I guess I better be careful. On this side, we have a comparison of all the medications of the benzos, and that's what we call for short is benzos. For diazepam, the onset of action is 1 to 5 minutes. The half-life is 30 to 60 hours, or 30 to 60 to 100 hours because of metabolites. Kind of hold it into the system. And yes, it has an active metabolite, so just know that holds on a little bit more. Metabolism is hepatic, excretion is renal, and dose adjustments, dose adjust per hepatic renal impairment. And then special considerations, you have erratic IM absorption, so it's not a great thing to give IM, and you can get some toxicity at very large doses. So midazolam, onset of action 2 to 5 minutes. Half-life is 2 to 6 hours, so it gets out of the system quicker. It does have an active metabolite, breaks down in the liver, and excretion is in the renal. And dose adjustments, you want to do it with the creatinine clearance of less than 10. And longer sedation in obese patients and those with low albumin. So think of those things when you're giving that drug. Lorazepam is 5 to 20 minutes of action, 9 to 21 hours as the half-life. And so it kind of holds on a good amount, but not too much. And it does not have an active metabolite. And it's broken down with the hepatic system, and it excretes with the renal and fecal. So you have a dual way of getting it out there. And Dose adjustments for renal impairment patients. You can adjust your doses, and risk of lactic acidosis and ATM with this one. Librium, I'm just going to call it because it's easier than me butchering the name, is given onset of action is 2 to 3 hours, and the half-life is 10 hours. And it does have an active metabolite. It's broken down in the hepatic system, and excretion is renal, and the dose adjustments not needed. But special considerations, you can have, please avoid in patients with significant acute or chronic hepatic dysfunction, significant renal dysfunction, or patients over the age of 60. And I don't think most people think about the 60 thing, but it can be really a hard thing on their systems. So when we talk about the CIWA-AR for monitoring withdrawal symptoms, it is a scale that has been studied, it's been looked at, and what it does is help give you a number to know how bad your patient is, and kind of it's taken to like a medication plan. So if the number's 8 to 16, you give this much Ativan. If it's 17 to 24, you give this much Ativan. If it kind of guides the nurse on how to treat the patient and keep them under control. So some of the symptoms that occur because of alcohol withdrawal is nausea and vomiting. So how bad is that? When you look at the one, it says none, mild nausea with no vomiting. And then there's 2 and 3. So you kind of between 1 and 4, which is intermittent nausea, you put how bad does it look? How often is it happening? And then 7 is constant nausea and frequent dry heaves and vomiting. So when you get to that 7, so 5 and 6, you might have a little bit of dry heaving, and 6, you might have a little bit of dry heaving and vomiting along with the nausea. So there is some subjectiveness to this scale, and that's probably the only problem, and some nurses really have a hard time with it. Part of the deal is the fact that if you kind of pay attention on this presentation, we're going to show you a video, and it was made by the people that kind of helped study the CIWA scale, and they present it in a very nice way, so it kind of helps you, and you'll be doing the scale on your sheet and then comparing it with them of what they found. Okay, so the second one is tremors, and it starts with it's from scale 0 to 7, and you can have the patient extend their arms and spread their fingers, and you can watch to see if they move them. And if they're not, some patients like benzos. They just want the benzos whether they need it or not, so they will sometimes raise the number of the scale. So you have to kind of really watch that for patients, because they know what they're doing, especially if they're 4th or 5th time here, they know what they're doing. So just we'll give you some tips as we go about different ways to test your patients so it's not so hard. And then we have anxiety. It rates on a scale of 0 to 7, and it goes from no anxiety, patient at ease, to pretty much a panic attack, severe delirium, or acute schizophrenic reaction. They are out. It is nuts what's going on with them. And then the next one is agitation, and it goes on a scale of 0 to 7. 0 is a normal activity, and 7 are pacing back and forth or constantly thrashing about. And the proximal sweats, so you're just looking at the patient. Can you see any kind of sweatiness on them? So rating a scale on 0 to 7. 0 is none. It's 7 is reaching. It's drenching sweat, so you have to change their clothes continuously. they're really having a rough time. And then we start getting into the really scary things. Orientation and clouding of sensorium. So, what day is this? What are you? Who am I? Where are you? Who am I? And the scale's 0 to 4. So if they're oriented or they're disoriented to place and they don't know what's going on. And then we go to tactile disturbances. So they're starting, are you having experience any itching, pins and needles sensation, burning or numbness, or a feeling of bugs crawling on or under your skin? And you can look at them and see if they're, they'll tell you if they're itching or no itching or mild itching, or if they're starting to have hallucinations. And then we go into audio disturbances. Are you more aware of sounds around you? Is things sounding harsh to you? Like when I talk to you, does it sound harsh? And do I startle you? Do you have anything that disturbs you or that you know isn't there? So are you hearing things that you know aren't there? And then you go from not present to continuous hallucinations. And they may not be able to talk to you about it, but you can kind of tell what's going on. Visual disturbances, you asked, does the light appear to be too bright? Is it color different than normal? Does it hurt your eyes? Are you seeing anything that disturbs you or that you know isn't there? So it goes from not present to continuous hallucinations. And then we have the headache, asking, does your head feel different than usual? Do you feel like there's a band around your head? And do not ask them about dizziness or lightheadedness. This is not part of the question. So it's either not present or extremely severe. They're having a really bad headache. So now we're going to talk about it a little more in detail, the CIWA scale. So the first one we're going to talk about is nausea and vomiting, rating on a scale of 0 to 7. So 0 is none, and then 1 is mild nausea with no vomiting. And then you go to 4, which is intermittent nausea. So somewhere between 1 and 4, you kind of have to figure out what that would be. So 2 might be mild nausea with maybe a little more frequently. So, and it's getting really uncomfortable for them where they're kind of moving around because they're so. And 3 would be a little more frequently the nausea and they feel like they're going to throw up. 4 is more intermittent, but then we go to 7, which is constant nausea and frequent dry heaves and vomiting. So 5 would be maybe continuous nausea and some dry heaving. Maybe 6 would be continuous nausea, some dry heaving, and maybe vomiting once. And 7 would be constant nausea and frequent dry heaves and vomiting. So it just kind of keeps going. It's a little hard sometimes. So the second one is tremors. So if you have your patient extend their arms and spread their fingers, and you watch it, and on a scale of 1 to 0 to 7. So 0 is no tremor. 1 would be not visible, but if you put your fingers to their fingertips, you can feel a little bit of movement. And then 4 is moderate with arms extended. So you're seeing some movement, but 3 would be slight movement maybe, and 2, you might be just seeing the fingers move some. So, and then when you go ahead to the next part, 7 is severe, so their arms are just wobbling around and they're all over the place. In between 4, so 4 is moderate with arms extended, so 5 would be a little bit more worse, and 6 pretty getting severe, and then 7 is severe, even with the arms not extended. So some patients can really fake out the nurse. They love doing that. And, people don't become addicts of any kind without learning how to work the system. I'm not telling you all people do that, but, people do learn it. And so with the tremors, if you feel like they're just kind of making that number up because they want. You could kind of tell they're faking it. Some are really good at faking it, but you can kind of tell by looking at them. You can have put their arms out and put your, feel their hands on it and kind of watch them. Or another one is you can do is have their stick their tongue out and watch them to see if it vibrates, because it's a systemic issue going on here. We're just looking for different areas, and they can't control that generally. And then the last one is to put your finger out and move it back and forth and tell them to watch it with their eyes, and you'll see the vibration of the eyes. So just some different ways to kind of do it to figure out what's going on with them. Anxiety, you rate it on a scale of 0 to 7. No anxiety, the patient is at ease, they're really relaxed, and maybe 1 is mildly anxious. Anxiety is really an inner thing, not an outer thing. You can see a little bit of anxiety, but you just ask them how they're feeling. Are you feeling anxious? And then 4 is moderately anxious or the guarded, so anxiety is inferred because you feel like they're really tense. So between 1 and 4, you kind of find, it's getting more. 2 would be a little bit more anxious, and 3 would be a little bit more anxious, and then 4 is moderate, and then 7 is complete panic state. So 6, you would see them getting a little more agitated, a little more severe, a little more active, and 5 more than moderate. So I'm not telling you this is easy to do, but you kind of get a feel for it after a while. Agitation, rate of scale 0 to 7. Agitation is normal activity, so they're not doing anything. 1 is somewhat normal activity, but they might be just moving their foot a little bit more. Just make sure that's not something they do every day, because if it is, then it's not different. And then 4 is moderately fidgety and restless, so somewhere between a little more active. So 2, you would see a little bit more active. Maybe they're, kicking their leg a lot or something, and 4 would be a little bit more restless, and 4, they're heading fidgety, restless. 5, they're getting worse, so they're moving around, maybe picking things up, looking at it. 6 is maybe they're getting out of bed occasionally. 7, pacing back and forth or constantly thrashing about. Proximal sweats, rated on a 0 to 7 scale. 0 is no sweat. 1 is barely perceptible, so you might touch their hand to see if you feel a moisture. If their spouse is there, you might say, are they a sweaty hand person? Because some people are. 2, you're going to see a little bit more moisture on them. It's kind of like watching somebody at the gym. They just start off with a little bit of sweat, and then if they're really going all out, by the end they're drenched, right? And some people sweat more than others, so the moisture is going to pick up, and by 4, their beads of sweat are obvious on their forehead, so you can't really miss. And 5, I always think of the one guy I had that just had this drip that dripped down, was continuously starting to drip down the sides of his head. And then it gets worse with 6, and then 7 is they're drenched, so you might have to change their shirts pretty frequently. But you're kind of missing the bus. If they're getting this far along without getting anything, you're missing the bus, and you're not going to be able to get them under control. So orientation and clouding sensorium. So rate 0 to 4. Luckily, these kind of tell you exactly what you need to do. You ask what day is it? Where are you? Who am I? 0, they're oriented. 1, they cannot do serial additions or is uncertain about the date. 2, and with the serial addition, so if they're not sure about the date, like let's say they know who you are, they know the building they're in, but they don't know the date, you can see how bad things are getting. So they can't do additions, like 1 plus 3, 2 plus 3 equals 5, and then you say, 2 plus 5 equals 7, 2 plus 7 equals 9. If they aren't able to do that, then you know 1 is where they're at. If they get a 2, they're disoriented to date by no more than 2 calendar days. And we all do that, right? Like on Tuesdays when it's really a bad week, I'm thinking it's Friday, and I think it's the fact that I want it to be Friday, but I'm thinking it's Friday. I'm not sure what day it is. And then 3, disoriented to date by more than two calendar days. So 4 is disoriented to place and or person. So they have no idea who I am, where, anything. So tactile disturbances, scale 0 to 7, you ask the questions like, are you having any itching? You feeling any pins and needles sensations, burning or numbness, or feeling of bugs crawling on or under your skin? You know, make sure that some people get itchy when they're nervous. They have that itchiness. And if they're diabetic, they might feel pins and needles or burning sensation or numbness in their feet, or, you know, they might. So just, you know, always make sure that it's not something that truly they have. So 0 tactile disturbances, none. 1 mild itching, pins and needles, burning. And then 2 is mild itching. So 1 is very mild, and then 2 is mild, and then 3 is moderate. So it's just getting worse as time goes on. And then they start hallucinating at 4. So 4, they're hallucinating that maybe ants are under their skin, or something's under their skin, spiders or something. And then severe hallucinations, they're feeling something really going, they're really itching or trying to get it out. And then extremely severe hallucinations, they start really being dangerous to themselves. So I know on one of the units in the hospital, they actually had somebody that tore their skin. And you know, that's got to be a horrible thing to deal with. And then 7, they're just having continuous hallucinations, tactile hallucinations. And then we have auditory disturbances, scale 0 to 7. You know, you ask the questions, are you more aware of sounds around you, or are they harsh? Do they startle you? Do you hear anything that disturbs you, or that you know isn't there? 0 is not present. 1 is that, you know, things are a little harsh or startle me a little bit. 2 is mild harshness or ability to startle. So, and 3 is moderate harshness or ability to startle. So they get really startled easily. 4 is moderate hallucinations, so they're starting to hear things. Maybe somebody talking, maybe they're thinking they're hearing people laugh in the hall at them. Like sometimes people think people are making fun of them. 5 is severe hallucinations, so they're getting worse. Things are getting worse, so they're not hearing as well or not able to respond to as well. And 6 is extremely severe hallucinations, so they're really hearing a lot. And 7 is just continuous. And you have missed the boat if they've gotten this far. You should just take them to the ICU, intubate them, and put them under sedation. Visual disturbances is kind of scary for them too. You ask, does the light appear to be too bright? Because they may ask the room to be turned down because maybe it's just bothering them. Is the color different than normal? Does it hurt your eyes? Are you seeing anything that disturbs you or that you know isn't there? And 0 is not present. 1 is very mild sensitivity. 2 is mild. 3 is moderate, so they're being more disturbed by the light, bothering them a lot. And they moderate hallucinations at 4, so 4 seems to be the magic number of hallucinations. So 5 is severe hallucinations, so they're seeing a lot of things. They're seeing spiders, they're seeing people. 6 is extremely severe, so they may not even be able to tell what's going on between the hallucinations or you. And 7 is they're gone. So you have that. You've got some severe issues going on. So when you're asking the patient about their headache, You need to kind of look at them and see if they're holding onto their head, asking, does your head feel different from usual? Does it feel like there's a band around your head? And don't, if they start talking about I'm dizzy or I have lightheadedness, don't make that part of it. 0, they don't have a headache at all. And 1 is very mild, a little achiness. 2 is mild. 3, it's getting a little more painful. And then 4, it's starting to really be a problem. And 5 is pretty severe. They're wanting the lights down low and they're wanting it quiet. And 6 is very severe. And 7 probably would be a 10 on a scale of 1 to 10. So that one you're going to treat with medications, also treating them with their CIWA. So it's part of the scale, and it helps you know how bad things are going for that patient. So benzodiazepines treatment programs, every physician has a different way that they do this. They will do a fixed dose to prevent symptoms. So if they really don't think they're going to go into severe withdrawal, and this is what they do if they do home treatments, they might put them on Librium, every 8 hours. And sometimes that works. It's great in the hospital if that's the thing that fixes them. And then over time they wean it. Like they might put them on 50 and then they turn it down to 25. And then they, cut it down to, Q12. So they kind of taper the dose. So as the benzos take over that, when things are evening out between the GABA and the glutamate, as they're getting better, you're weaning off the benzos so the GABA can completely get back to normal. So 2 is the fixed tapering dose used out of patient, not monitored patient, so you're not doing the CIWA scales on them. You're not going to fix it. 3 is front loading dose. So those with severe withdrawal, we're going to give a lot of meds, get a bolus and trying to get a blood level up. And then we're going to keep giving those meds as they need it. And some docs believe in symptom triggered treatment goals used with scales. So that's kind of what we do, but every doctor does it different. Some of them put them on Librium and they just have Ativan for breakthrough. Some of them put them on Ativan, PO, Q4, and then put IV for breakthrough. Because, day 3, they might look good. Everybody's going, oh, this is going great. And then day 3, the world hits and 4 o'clock comes on Saturday and it's day 3. God knows I'm going into DTs and people better get things on board. So I'm not saying that I'm just saying if that were the case. Okay, so whatever's ordered, it's your job to notify the physician if the medication is not holding the patient under control. So that's why you're doing the CIWA scales on a regular basis. We do it every 2 hours here. We tell our nurses to wake the patients up. It is like a neuro check because, I used to look at the numbers, and I would look at every 2 hours, and they, at 12 they would be 0 because they would be asleep, and it's not fun to wake these patients up. But if you don't wake them up at 1, they're an 18. So, and you can do it quickly. You can touch their hand to feel for moisture. You can just have them hold it out. It's a discussion you have to have, like with patients with neuro checks. You have a discussion that they're here to, they're going through withdrawal, so you're trying to prevent and keep them safe. So you're going to wake them up every 2 hours, and this is what's going to happen. So I'm not telling you that makes it any easier, but sometimes you just have to be just up front. And if it's not working, you need to call the physician and get it going because it's only going to get worse. And you can use the resources at your hospitals that help you. We have rapid response. We have our lead nurses. We have our AL, and our docs are pretty responsive most of the time. So some other things that might be given to somebody if they're worried about if patients are going through DTs, so 5%, most of the time if they're going through pretty severe, you're going to put them in the ICU, or maybe a step-down unit where they have the staff load to take care of it. So phenobarbital's, it's effective when used with benzos for these patients who are in DTs and are resistant to withdrawal. So it kind of helps everything come together. And usually these patients are intubated in the ICU and the medication is given via infusion, just like propofol. It's kind of the same way. And some patients, they'll come in, and I remember this guy, well, I'll tell the story later. And ketamine is used with patient DTs along with benzos. But those have to be in areas where they can be monitored pretty constantly. So there's several vitamins that your patients need to have. And the key ones are vitamin B, thiamine. Prophylactic dose, you can give it in tablets, 100 milligrams daily for 3 to 5 days, or vitamin B1 injectable, 100 milligrams IV every day for 3 to 5 days. Folic acid, 1 milligram PO daily, and they usually give a multivite because they've lost a lot of other electrolytes due to excessive alcohol consumption, like magnesium, calcium, zinc, iron, potassium, vitamin A. There is one thing that we give the vitamin B1 for, is to prevent Wernicke encephalopathy. It's when a patient is low in thiamine due to poor nutrition and the GI tract is really swollen and they're absorbing slowly. So it can be deadly for these patients. So signs and symptoms are Wernicke syndrome, which is confusion, loss of mental activity that can progress to coma and death, and loss of motor coordination. So we give vitamin B just in case. They could use it anyway, but we really want to prevent this from occurring because we don't want them dying from that part. That's it. Thank you. So kindling. So those patients that come in pretty regularly and go through withdrawals over and over again, these repeated episodes of excessive alcohol consumption and then subsequent withdrawal have an increasingly worse consequences on the neurons. And what they do is can have some long-term neuronal changes which occur with multiple detoxifications and results in increase in severity and increase in severe manifestations of acute withdrawal syndrome. So every time they come in and they're going through withdrawal, it will get worse. And you will have a harder time getting them under control. So I had this guy that he had some arterial peripheral vascular disease. And so they kept bringing him to IR, and he would be admitted through the IR, and by the time he would get to me, I seemed to always get him too. He would start going through withdrawals, and it was pretty quick. He didn't take very long, and he would so by the third time I had him, I just called the doc and say, let's intubate him now, because it just took everything. And at first they were trying not to intubate him or and they realized that they couldn't. And he had an arterial line in, so he had no business going through DTs. So the primary objective of alcohol withdrawal syndrome is, number one, reduce symptom severity. So making sure we keep the symptoms calm and relaxed and down. Because the more you leave it go higher, the harder it is to get under control. Number two is prevent manifestations of the more severe withdrawal symptoms like seizures, DTs, the hallucinations. And three, allow facilitation of patient into a treatment program to support long-term alcohol abstinence. And we do have a program here. He's basically, we call him the SUN, Substance Use Navigator, and he sees patients that are here going through withdrawal from alcohol, and he'll come up and talk to them, trying to get them into long-term alcohol programs and opioid abuse. He does all. He's kind of a godsend because nurses don't really, don't have a lot of time to sit there and be a therapist. We do have our psych liaisons at our hospital too that come up and see the patients, and the psych physicians also, trying to talk to them about getting help outside. So implicit bias, and we always have to talk about implicit bias. It's kind of the key thing now. It's the negative evaluation of one group and its members relative to another. So biases exhibited by healthcare workers can result in rushed or inadequate patient assessments. Yeah, and you've seen that. Everybody's seen that in their career where people, they think that alcoholics have done this to themselves, so they don't need to be treated as nice, so they rush in. Plus, they're kind of scary people. They're a lot of work, and so you want to rush in and rush out. But you need to do the assessment because that's what we're here for. And believe me, if you can keep it under control for that patient, you are saving yourself and that patient a lot of pain. Concerns and questions are not taken seriously or fully addressed. If the person's hallucinating and the nurse treats them badly, it's very upsetting to the patient, and it makes them, a lot of code greens I think are probably from that. People are kind of sarcastic and rude, not thinking about what they might be sounding like to the patient. So you need to pay attention to that. Less time devoted to patient care, so you're not giving the care that they need and deserve. Incorrect diagnoses because we're not paying attention to things. Inappropriate treatment plans, so the care that we're giving is not necessarily the right thing. Excuse me. And lack of patient follow-up, especially after discharge. So they're not getting the care that they need while they're in, or the respect that they need, and they're not getting the care that they should get going home. So when talking about dealing with patients who have substance abuse, they found that words matter. And you probably have heard this several times in your existence as a nurse. According to research that was published in the American Journal of Medicine, it was found that not only do words shape how we see people, but it also affects how we treat them. There are many studies that have been shown that people that use negative language when speaking about someone with a substance use disorder tend to believe that person should endure the symptoms of withdrawal rather than help and support the patient. Words such as addict, IV drug user, drug abuser, alcoholic are some of the verbiages that healthcare workers need to change. Some of the examples of change in verbiage that they put out there for us to do are persons who use drugs instead of saying the word addict. So addict is very negative connotations. Person who uses drugs isn't necessarily a great thing either, but it's not as harsh. Person who injects drugs instead of IV drug user. So just changing our language to be a little bit more up than accusing. Person in recovery instead of former addict. And the patient is positive or negative for drugs rather than clean or dirty. And that's probably the one you really can go, yeah, that's a little bit over the top. So many patients feel guilty for their drug use because many of them know it's not right. And here they are in the hospital being treated. And, none of us like those things that we have that we do wrong in our lives. So we'll have to kind of put ourselves in their shoes. So if they're put into an environment that treats them in a negative manner, it causes the guilt and shame to worsen and causes them to lie about their use despite how bad it might be. It also can make people angry. And sometimes I think code greens or people act out because they don't know what to do. They don't know how to handle how things are going. And obviously they don't handle things well because of, kind of what they're doing to their body. But, treating with all people with respect. Doesn't mean you have to agree with them, doesn't mean you can't set parameters with them, but you need to treat them like people, with respect as human beings, as you would hope the world would treat you. So that's all I'm going to say on that. So can you see what I see? So this is not something I made up, although I wish I could say I was that clever, but I'm not. So this is was done by a nurse. I was looking at all this information and I thought that was a clever way of saying it. So what we're going to do is we're going to watch a YouTube video that was done by a hospital up in San Francisco, and they're going to act out a CIWA scenario. And while they're doing that, I want you to take the sheet that was sent to you. It's the CIWA sheet, and look at, go through the scales and choose what you think is going on there. The doctor will ask the patient questions and you decide by the answer what should be. Now I am going to apologize because the CIWA scale that I'm sending you does not match the how they do it. So it starts with nausea and vomiting, and it goes to tremors, but then it might go to hallucinations. So you kind of got to follow what they're saying and look on the sheet and then decide. And then at the end of it, you compare your numbers to hers and see how close you were. Okay? So it's a really good video. And by the way, she is oriented because it was shot in 2012. So she is oriented. Okay, so let's go on to the second set of scenarios. And the second scenario to watch, I call it, so you think you can guess what a patient's CIWA score is? Guess again. This scenario you need to watch. There are 3 parts, and each section the patient gets worse. So watch each section, pause the video, guess what you think the CIWA score is, and then we'll discuss it on the slide after the videos. Okay, so after looking at the video, when you stopped after the first section, what did you find? So without asking the patient any questions, what would your score have been for that patient? So I sat there and I looked at it myself, and I felt like I would have thought he was a 4. Didn't know if he was nauseous. Didn't know if he had tremors. Maybe I might have given him a point for anxiety, but I'm not sure. Agitation, I would give him 4 or 5 because he was moving around a lot. So maybe he might be 4 to 6, somewhere in there. But if you can't ask, you cannot tell what's going on. And you need to feel his fingers to see if he's tremors, because later on you think, my God, he must have been. Because, wow, he was really flapping around. And his palms for moisture and how is he feeling? He's probably an 8 to 12, which at my hospital, an 8 is a good reason to give a medication. So we at our hospital we say less than 8 is great because the scale starts at 8. It goes 8 to 16. You give 1 milligram Ativan, and 17 to 26, I think it is, you give 2 milligrams of Ativan. Everybody does it a little different, but that's how we do it here. So after the second video, the patient, he's definitely showing more signs and symptoms, but you're still not getting the whole picture. So he wasn't nauseated or vomiting. You didn't even know if that was occurring. You saw the tremors when he picked up the water pitcher. He spilt everything all over, and he was getting anxious and uptight. He was agitated, definitely moving around, pulling at things, picking at things, and he was having sweats. You could see the sweats on him. But you didn't know if he was oriented. You didn't know if he was having tactile disturbances at that point. He was hitting at things, but you weren't sure how far it was. And auditory hallucinations, you don't know, or visual disturbances, you're not sure, or a headache, you don't know. So just with this alone, he would be, I don't know, I have 5, 10, 11, 15, maybe 16. So you're thinking 16, well, that's pretty high, but he probably is really a lot higher. Or think if you had these prior during the first scenario, you might have been able to prevent it from going this far. If you don't aggressively treat this patient at this point, you'll probably transfer to on our step down unit or ICU and started on a drip, maybe even intubated at this point. But you're not sure because you're guessing and you're thinking what you're seeing. And then the third scenario, you can definitely tell, right? He's having tremors. You still don't know if he's nauseated or vomiting. You know he's somewhat anxious, but you're not really sure all the way. Agitation, yes, 7. Sweats, 6. And orientation, you still don't know about that. And tactile disturbances, maybe 3 or 4. Auditory hallucinations, you don't know, but visual disturbances, you know something's going on because he's seeing things and looking at things and kind of getting a little crazy. And his headache, you don't know. So the patient probably is way off the scale. I mean, I have it at 30 from my little assessment, but you may not be able to get control of the symptoms. And this is a really dangerous time for the patient. He should never reach this point for providing care appropriately. So you need to look and ask the questions so you can keep the symptoms under control and keep the patient comfortable and safe. Also to keep you safe too. It's scary when these patients have no touch with reality. You don't know how far they're going to go. Luckily, this guy put his shoes on and left, but it could have been very different. So I hope you learned from this, and I hope you can use this in your practice. Have a good day. Bye-bye.